Hello, my dear students. I am Dr. Aarthee from Vinaya Mission Dental College and I am working as Assistant Professor in the Department of Oral and Maxillofacial Surgery. Today we are going to see about Bell's palsy and its management. Let's start with our class. Today's class was Bell's palsy and its management. So these are my contents: introduction, anatomy, etiology, facial nerve grading and evaluation and management. So these are the sequences we are going to see today. So let's begin with the introduction. Now, what is palsy? So first, palsy is complete or partial muscle paralysis which is often accompanied by the loss of sensation and uncontrolled body movements. Second one is paresis. So paresis means muscular weakness. So there will be weakness in the muscle region. So paralysis means complete loss of muscle function. So there will be total loss of functions in the respective muscle. So first we have to know about the anatomy of the facial nerve. So on coming to facial nerve anatomy, so we have to go through the nucleus and fascicles, cysternal segment, intertemporal segment and peripheral segment. But mainly all the lesions are associated with the nucleus of the facial nerve. So what are the nucleus of the facial nerve? Superior salivary nucleus, nucleus of the facial nerve and nervus intermedius. So these are the nucleus associated with the facial nerve. So disorders of the facial nerve which is classified as upper motor neuron lesions and lower motor neuron lesion. The neurons to the upper face receive bilateral innervation from the lower motor neurons. Then the neurons to the lower face receive upper motor neurons from the contralateral motor cortex. So the facial nerve palsy is categorized and classified as lower motor neuron and upper motor neuron. Lower motor neuron which is associated with forehead muscles affected. So all the whole upper face and lower face will be affected in the lower motor neuron lesions. In the upper motor neuron lesions, only the lower muscles will get affected, not the forehead muscles are not and all affected. So for example, all the cortical or brainstem infarct, intracranial tumor will rise to upper motor neuron lesion. So patient will get palsy in the lower half of the face. But in lower motor neuron lesion like Bell's palsy, so patient will be affected on like complete face, both the upper and the lower face get affected. So further they classified the lower motor neuron lesions as idiopathic, traumatic, viral, neoplastic and other causative agents. Bell's palsy which is resulted from other causative agents like acute or chronic otitis media, malignant otitis extrema, Lyme disease, or sometimes it might be not have etiological reasons also. So these are the localization of the lesions which are affecting the facial nerve. First, these are the site of damage, facial nerve signs. These are the common associated features which will be resulted by the damage of the particular site of the facial nerve. So if the lesion was located in the cortex or subcortical involvement, so patient will be having the central facial nerve weakness and lacrimation, salivation and taste and all will be intact. When the lesion was in pons, so patient will have ipsilateral peripheral facial weakness and lacrimation and salivation and taste will become intact. Then in case of cerebropontine angle or facial nerve in internal auditory canal proximal or involving geniculate ganglion, or it involved with the distal to the internal auditory canal and geniculate ganglion, or facial nerve is in the stylomastoid foramen will get involved, patient will be having ipsilateral, it is like same side peripheral facial weakness including lacrimation and salivary function also will be not functioning. So these are the common features associated with this site damages: tinnitus, nystagmus and hearing loss. So these are the features we have to notice in the Bell's palsy patients. And etiology, and coming to the major part, what is the etiology of the facial nerve palsy or Bell's palsy is, this is classified according to the course of nerve and various etiological causes and degree of dysfunction observed. So what are the intracranial causes which leads to facial palsy or vascular abnormalities? That is CNS degenerative diseases, tumors of the internal intracranial cavity, trauma to the brain will leads to facial palsy and congenital abnormalities. Then intratemporal causes which are like bacterial and viral infection may leads to Bell's palsy, cholestema, trauma, that is like blunt trauma to the temporal bone, and tumors invading middle ear, mastoid and facial nerve will rise to Bell's palsy, and sometime it might because of iatrogenic causes also. In case of like parotid tumor excision will leads to, sometimes it will leads to facial nerve palsy. These are the neurological causes, that is like myasthenia gravis, multiple sclerosis and Guillain-Barré syndrome. So these are associated with the neurological causes of Bell's palsy. And neoplastic causes or facial nerve tumors, meningiomas, acoustic neuroma, parotid tumors, auditory meatus tumors will rise to Bell's palsy. And these are the infections which leads to facial nerve palsy or otitis media, mastoiditis and Ramsay-Hunt syndrome. While approaching these cases, so we have to closely watch the patient for any facial palsy. So we have to evaluate the function of the facial nerve. And these are some hypotheses which may be leads to the causes of the Bell's palsy. Or first is rheumatic hypothesis, which is given by Birard in 1936. He suggested rheumatic swelling may press the nerve against the facial canal, so which leads to the Bell's palsy. And the cold hypothesis, which is given by Bell, he is telling like exposure to the extreme cold or drought will leads to facial palsy. And in ischemic hypothesis, some disturbed circulation will leads to ischemia, so that will leads to Bell's palsy. Immunological hypothesis, so in vivo sensitization of lymphocytes to the peripheral nerve myelin sheath will lead to Bell's palsy. And viral hypothesis is HSV, that is herpes simplex virus, elevated viral antibody titer and interferons will lead to facial palsy along with accompanied with the herpes simplex virus infection, which is called as Ramsay-Hunt syndrome. So these are the conditions we will be going to see through our future slides. So what are the factors which producing vasospasm, like according to the ischemic hypothesis? Okay, so according to the ischemic hypothesis, so these are the factors, okay, which leads to further compression of the nerve and that leads to Bell's palsy. So these are the factors. So cold may leads to ischemia, that is vasospasm, anoxia, CO2, that is excess of CO2, vasomotor instability, sometimes injury, and toxic, sometimes it's like some allergic reaction or hormonal influence may leads to Bell's palsy. So these are the facial nerve grading which usually helps to predict the treatment plan for the Bell's palsy. Okay, so this is the main key to manage the Bell's palsy condition. So this is given by House-Brackman grading scale. Okay, so this is given by House and Brackman. So let me tell the grading. So he graded the palsy from 1 to 6, from normal to total paralysis of the face. So in total paralysis there will be no movement at all. In severe dysfunction, at rest asymmetry will be there and motion in the forehead region, so none of the expressions or none of the wrinkles will be formed. So this is called a severe dysfunction. And in the grade 6 or total paralysis, there will be no movements will be evident. So what are the clinical examinations? What are the things we have to examine the patient? Is While inspection, we have to note for the facial symmetry at rest position. So we have to ask the patient to rest. In that, you have to watch the symmetry of the facial expressions. Then in resting positions also, you have to watch the facial symmetry and in expressions also. So we have to ask the patient to wrinkle his forehead, we have to ask the patient to buff his cheek, so we have to ask the patients to blink, and we have to ask the patient to smile. So by these expressions we have to notice, so we can be able to notice any lesions in the facial nerve. Okay, so atrophy or fasciculations, spontaneous blinking, and synkinesia, nasolabial fold with forehead wrinkles, and width of the palpebral fissure. So these are the things we have to see in inspection. So in facial nerve palsy patients, there will be, the patient can't be able to wrinkle their brows. Okay, so the affected person may not be able to raise one eyebrow and wrinkle the forehead, and the drooping of eyelids and inability to close his or her eyes, an asymmetrical smile, so the patient will be losing their confidence. So they must need the exact management of the Bell's palsy. So asymmetrical smile and drooping corner of the mouth due to the involvement of marginal mandibular nerve. Okay, so how to examine this? So first is examination of the sensory function, which is evaluated by, we have to take citric acid and taste, we have to check the taste on the anterior two-third of the tongue. So we have to test for salty, sweety taste, bitter and sour taste. And hypaesthesia of the posterior wall of external auditory meatus, which is due to the proximal lesions in the facial nerve. For the testing of the temporal branch, we have to ask the patient to wrinkle his or his forehead region, and testing the zygomatic branch. So we have to ask the patient to close the eyes tightly like this. Okay, then testing the buccal branch, we have to ask the patient to puff up their cheeks. If the patient can't be able to puff up their cheeks, so this is due to any lesions in the facial nerve, or the buccal branch of the facial nerve will get paralyzed. In that condition, so the patient can't be able to puff his or her cheeks. Then examination of the secretory function, which is obtained by taking history and observation. So we have to watch the patient for tearing, okay, tearing and salivation. Then lacrimal and nasolacrimal reflex we have to check in the patient. So the test associated with the checking of the tearing or lacrimation of the eye is Crimmer test. So in that, the bitmus paper will be placed in the lower eyelid, and we have to check for the tear protection. So normal tear protection, I will see the level of the bitmus paper impregnated into the tear, and this seems as a insufficient tear protection. Okay, so examination of the reflexes. So we have to watch for the corneal reflex, which is afferently innervated by the 6th cranial nerve and efferently innervated by the 7th cranial nerve, that is facial nerve. Stapedius reflex, by impedance audiometry we have to notice, like tympanometry, we have to note, we have to like check for stapedial reflex. Absence or reflex less than the half the amplitude, which is due to the lesion located in the proximal to the stapedius nerve. So which is mostly due to which will characterize the location of the lesion, or where it is located. So if it is beyond, if it is like proximal to the stapedius nerve, then in stapedial reflex we will get absence or reflex which is less than the half the amplitude of the facial lesion. So this is Chauvistic sign. Okay, so this, by this also we can notice whether the patient is having like normal reflex or, so this is the pattern. Here they are checking for Chauvistic sign. Okay, so topodiagnostic testing. So in this we are having scrimmage test, already we discussed. This is to assess the greater superficial petrosal nerve, and stapedial reflex, which is due to assess the nerve to stapedius muscle. And electrogastrometry, this is nothing but the test to evaluate the taste senses, which is usually assessing chorda tympani nerve, and salivary flow testing, which is for assessing chorda tympani nerve. So on coming to Bell's palsy, which is nothing but the common cranial neuropathy which is caused due to acute unilateral lower motor neuron facial paralysis, which is first demonstrated by Sir Charles Bell, so it is named as Bell's palsy. So what are the etiology associated with Bell's palsy? First is herpes simplex virus, trauma and infection, nerve compression. Sometimes it might be due to idiopathic regions also. So what are the clinical features? Let me see. Like unilateral involvement. So Bell's palsy will be confined to the unilateral side. So this is the key feature of the Bell's palsy. Okay, so unilateral involvement, there will be absence of wrinkles. So see, there is no like wrinkles in the opposite side. So this is a characteristic feature of the Bell's palsy patient. So the Bell's palsy is lower motor neuron lesion. So loss of blinking will be there, inability to close his or her eye, inability to whistle, so inability to puff the cheeks, obstruction of the nasolabial fold, drooping of the corner of the mouth, and the face will be like expressionless face. So it is said to be mask-like appearance of the face. So Bell's sign, what is Bell's sign? In an attempt to close the eye lid, the eyeball turns upward so that the pupil is covered and only the white sclera is visible. So this is termed as Bell's sign. On coming to Ramsay-Hunt syndrome, which is mostly due to lower motor neuron lesion, which is associated with varicella zoster virus. So Bell's palsy along with varicella zoster virus, it is said to be Ramsay-Hunt syndrome. Okay, so what are the clinical features of the Ramsay syndrome are multiple erythematous vesicular rashes on the ear and in the mouth. So these are the rashes. Okay, so these are the rashes which is usually acknowledged in the unilateral side. Okay, so unilateral vesicular lesions of the oral cavity and the tongue, ear. Okay, so often we have to examine the patient for the Bell's palsy also. So this is called Ramsay-Hunt syndrome. So what are the signs and symptoms? So rashes in the ear and tongue region, in the mastoid region also, vertigo, nystagmus and vomiting. So this is a characteristic Bell's sign. Okay, so these are tinnitus, nausea, vomiting, facial paralysis. And Bell-Carson-Rosenthal syndrome, this is called as orofacial granulomatosis, and this is a triad. Okay, so usually it is accompanied by facial paralysis, and our patient is also experiencing fissure tongue. So there will be multiple fissures in the tongue and recurrent orofacial edema. See the edema in the lip. Okay, so the patient is accompanied by facial palsy, fissure tongue and edema. Okay, so this is called as Bell-Carson-Rosenthal syndrome. And how to manage? So management is the most important step of the Bell's palsy, because it is known to improve the psychological condition of the patient, because mostly the Bell's palsy patient will be so depressed because of the facial appearance. They can't be able to smile properly, they can't be able to lift his or her eyebrows, so that will be so annoying the patient and it will be disturbing the social life of the patient. So we have to manage the Bell's palsy patient. For that we need to evaluate the patient properly. Like we have to evaluate the clinical features and we have to do proper diagnosis. Like diagnosis is most important in the Bell's palsy patient. So these are the conservative management, like massages. So first massages. Okay, so the facial massages will be very useful for the Bell's palsy cases, but in mild, moderate cases, and all will be benefited by long term facial massages. Okay, so these are the proven thing, and artificial tears will prevent the corneal ulceration, because it must needed to prevent the corneal ulceration. Okay, so facial massages plus exercises and eye care. Eye care is mandatory. Okay, so we can place the gold weight in the upper eyelid, so we have to, like, the patient can't be able to blink, right? So that will be needed for the management of eye care of the patient. So these are the medical management of the Bell's palsy patient. So first is use of steroids. So what are the what is the choice of the steroid for the Bell's palsy patient? That is prednisolone. So 50 milligram of prednisolone once a day should be commenced for 7 to 10 days of duration. So prednisolone 50 milligram once daily, it should be for the duration of 7 to 10 days. Okay, then in Ramsay-Hunt syndrome, so we have to treat the varicella zoster infection, so we must be needed for the antiviral. So what is the choice of antiviral? Acyclovir. Acyclovir 800 milligram 5 times a day for between 7 to 10 days. Okay, so steroid therapy is mandatory for the patient. We have to give analgesia for the pain, and steroid therapy, that is nothing but prednisolone 50 milligrams along with to treat the varicella zoster infection. So we have to give acyclovir for the patient. So these are the surgical management. The first is electromyography. So we have to check the action potential generated by the muscles innervated by the facial nerve. Okay, so this is the must for evaluation of the facial nerve. And for acute suppurative otitis media along with mastitis or laryngotomy, so the patient will be needed for ventilation tube and cortical mastodectomy. Okay, so these are the surgical procedure involved. Iatrogenic causes, which is due to the compression of the facial nerve due to the tumor and all, so we have to decompress the facial nerve by excision of the tumor, or along with the nerve grafting also sometimes needed. So cable graft will be the suitable option for the nerve grafting, and sometimes we have to go for tensionless repair of the facial nerve. If it is not possible, we can go for cable graft. So in temporal bone fracture, sometimes the fracture fragment will impinge on the nerve and it compressed on the facial nerve will lead to facial nerve palsy. So at the time we have to release the compression. So decompression is needed at the time. So this is the normal and this is the compressed bone, and this is after decompressment, see the nerve. Okay, so decompression sometimes will help to relieve the facial palsy symptoms. So we have to evaluate, the evaluation must be needed for the exact and proper management of the Bell's palsy. So these are the types of surgery associated for the management of the facial paralysis. So first is facial nerve decompression in an options of virally induced facial palsy. Okay, so we have to decompress the facial nerve like I previously told, like this. Okay, so facial nerve repair techniques can subclassify into primary repair and cable grafting. So primary repair is usually tensionless. Okay, but in case of we need graft, so we have to go for cable grafting. Okay, so if the nerve can be repaired like primarily without the need for any graft, so this is called as tension free, so it is said to be primary repair. So primary repair will result in a proper prognosis of the Bell's palsy patient, but in cable grafting, case of tensionless repair, cable graft is the suggested treatment option, like surgical treatment option of the Bell's palsy. So what are the graft we can use for the Bell's palsy management, especially for the cable graft, is medial and lateral antebrachial cutaneous nerves and greater auricular nerve and sural nerve. Okay, so these are the nerves we can be used for the nerve graft. So these are the nerve graft techniques. So this is sural nerve taken from here. Okay, so they zoom in that area here. So this is a large neuroma at the proximal anastomosed site of the previous repair. So neuroma resection done. So they resect the neuroma and the previous graft resected and nerve debridement back to the healthy edges. So this is called as primary repair. Okay, so 20 centimeter of the length of the sural nerve harvested, then the sural nerve harvested. So we have to harvest 20 centimeter. So according to the deceased now we have to harvest the nerve graft. Sural nerve graft taken from the site and graft segments anastomosed with the peroneal nerve fascicles. So anastomosed is covered with the nerve conduct protector. So like this. So these are the nerves we can use for the cable graft technique. And when to go for nerve grafting. So if the duration of the facial nerve palsy will be there more for from weeks to 2 years, so we can go for surgical options like nerve grafting. And muscle transfers may be indicated or suitable for those patients with chronic facial nerve palsy, like more than 2 years we have to go for muscle transfer. So we can take digastric muscle for the management of the smile correction, and we can take masseter muscle, and we can use temporalis muscle for the regional muscle transfer. Okay, so the regional muscle transfer most commonly utilizes the temporalis muscle, but however we can use digastric muscle for the marginal mandibular nerve injury, and for the masseter we can use masseter muscle for the smile reanimation. Okay, so these are the procedure. So TENS is having transcutaneous nerve stimulation is having very good prognosis in the Bell's palsy patient. To conclude my presentation, an extensive interprofessional team approach which consists of family physicians. So to follow the history, to know the history, so we need family physicians, emergency physicians, ENT surgeons, ophthalmologists and radiologists, neurologists and stroke physicians and maxillofacial surgeons are required to facilitate timely and accurate evaluation and treatment for the facial nerve palsies. So my dear students, thank you so much for watching my class. Thank you so much.